Hi everyone. Today I'm going to share a case which we encountered in the rheumatology clinic of a girl coming in for joint pain, which is not so straightforward and has put us in a dilemma of whether it is an infection or inflammation. So this was an 8-year-old girl coming in for painful swelling at multiple sites of the body, including the right heel, the left wrist, and also the right foot. And the pain, oh, sorry. Oh. I'm sorry, forgot to share the screen. So this was an 8-year-old that I was just talking about. She came in complaining of painful swelling at multiple sites, including the right heel, the left wrist, and also the right foot. And the symptoms has been there for around a year already. And so at this juncture, we thought about, okay, is it a bone problem or is it a joint problem or anything? So looking at the anatomy, we need to brainstorm about whether it is a joint problem, to be more specific, the synovium, or is it the bone problem, or is it the tendon that surrounds the joint that causes symptoms of this girl? And about the pathophysiology, is it an infection, inflammation, malignancy, or is it a trauma? More specifically, if it's the infection of the joint, okay, is it a septic arthritis, or is it a post-infectious reactive arthritis, or is it a post-streptococcal infection joint problem, which is known as the rheumatic fever? Or if it's the bone infection, is it osteomyelitis? But the girl said, I don't have a fever and I have no recent infection and I have no wounds or skin breakage that can lead to osteomyelitis. The second differential diagnosis is inflammation. If it's the joint inflammation, can it be a juvenile idiopathic arthritis, JIA, or systemic lupus erythematosus, SLE? And the girl had no oral ulcers, malar rash, abdominal or urinary symptoms suggestive of rheumatoid disorders, and also she had no family history of rheumatological disease. How about malignancy? Can it be leukemia or bone tumors that spread apart at different sites? But the girl had no constitutional symptoms, no anemia, and no bleeding symptoms. And finally, it can always be a trauma, but the girl had no history of trauma. So right now, what can it be? On physical exam, what we can elicit is erythema, swelling, and also reduced range of movement, and of course tenderness at these sites. Other than that, the girl has no other systemic features on the clinical exam. Of course, the next step is X-ray. Okay, looking at this X-ray of the right ankle, it looks pretty normal. And we order another X-ray for the joint of the wrist. Right, okay, so right here you can see some difference. On the left wrist, it looks a little bit ugly over the metaphysis of the left distal radius with mixed lytic and sclerotic lesion compared to the right side, which is normal. And onto the foot, okay, once again, you can see abnormality over here. There is erosion at the head of the right fourth metatarsal bone, this one, and also a lytic lesion at the metaphysis as well. So it narrows down to the pathology affecting the bone and not the joint. So we have osteomyelitis and different kinds of malignancy being our differential diagnosis. But looking at some other pictures of, the X-ray of osteomyelitis, these lesions are pretty similar to our girl. And looking at the X-ray of some malignancy, for example, the X-ray are also very similar. So how can we differentiate between infection and malignancy at this stage? Another investigation to go forward is blood test. For that girl, the white blood cells is normal. ESR is mildly elevated at 41, CRP is normal. And the peripheral blood smear shows no blast cells. Urate and LDH are mildly elevated, and she had negative autoimmune markers, including the rheumatoid factor and anti-nuclear antibody ANA. Okay, so next step, we order an MRI for the girl. Over here, you can see the MRI of both feet. And on the right feet, there is a heterogeneous hyperintense signal over the calcaneum, suggestive of osteitis. And over here, we are looking at the flexor hallucis longus tendon, and there is hyperintense signal, a little bit whitish in color. This suggests some effusion and synovial thickening, suggestive of tenosynovitis of the right foot. So probably explaining the erythema and painful swelling. An MRI of the wrist shows, again, asymmetry. So this one is the normal one on the right wrist, where the left one, where the girl is symptomatic, shows increased, hyperintense signal at the left distal radial metaphysis and epiphysis, suggestive of inflammation changes. So right now, our conclusion is that we see multiple abnormalities in different sites of the MRI and X-ray. How about the other joints on the body? Will they also be affected? So bone scan is arranged. Here we can see again, so these are the hands, suggestive of asymmetric increased uptake at the left wrist, which is compatible with the MRI, right ankle, right fourth metatarsal, right ankle, also compatible. And this is a whole body picture, again showing increased signal over the affected joints of the girl. And incidentally, there is also some increased signal over the left distal end of the humerus and also the right knee, but the girl has no symptoms over these two sites. So it put us in a dilemma. So there is a multiple site of infection, but of course malignancy is also one of our differential. So the girl underwent aspiration under ultrasound guidance, and it showed no growth on the culture and no malignant cells. And it's further confirmed by the open bone biopsy, which showed no malignant cells. Okay, so right now, it seems that infective osteomyelitis and malignancy are ruled out. So we are running out of differential diagnosis. What can it be? Oh, so there is actually an entity under inflammation, but specifically on the bone, called chronic recurrent multifocal osteomyelitis, CROM. What is it? Looking at the history, it was first described in 1972 by a Swiss pediatrician and radiologist. It is an inflammatory bone disorder, it's non-infectious, and somehow it is relapsing and remitting, and it's multifocal, can be symmetrical, and it affects children and adolescents. And that's why a few years later, it was renamed. So being an inflammatory bone disorder, it's renamed as osteomyelitis. Having the nature of a relapsing and remitting cause is called chronic and recurrent, and because it's multifocal. So overall, it's chronic recurrent multifocal osteomyelitis, CRMO. So what causes this disease? It's believed to be inflammation caused by abnormalities in the inflammatory cytokines, for example, the interleukins, 1, 6, 10, 20, or the tissue necrosis factor alpha, in short, TNF alpha. It can be sporadic, or it can also be monogenic. For example, it can be due to a specific mutation causing abnormality on the interleukin 1, or another gene causing Majeed syndrome. And it's known as an autoinflammatory disorder, which means it's it's the problem of the innate immune system without the presence of autoantibodies. So we can't check any specific autoantibodies that explains this disease. And being an autoimmune problem, it can also be associated with other conditions, for example, psoriasis, Crohn's disease, or a skin condition called palmopalmar pustulosis. And somehow in adults, there is a similar condition called Saffold syndrome, which mimics the childhood kind of CRMO. In this syndrome, it comprises of synovitis, acne, pustulosis, hyperostosis, and osteitis. In fact, this disease is very rare, and there are only around 2,000 cases all over the world until 2024, and it's more common in females. When it happens in males, the disease tends to be more severe and treatment refractory. The mean age is around 10 years old. And the presentation is just like this. So the child may have bone pain, bone swelling, and there can be local skin changes, for example, redness. And often it affects different sites of the body. And sometimes not only the bones, but the joint, the articular involvement, and the enthesitis, the tendons, can be affected. So as you can see, a few of them can present with also sacroiliitis, enthesitis, and arthritis. Less commonly, the child can have constitutional symptoms, fatigue, fever, and there can be skin manifestations, for example, pyoderma, acne, or PPP, pustulopalma, pustulosis. And on X-ray, for example, over the knees, they can present with sclerosis, and on MRI, they can look like increased, there can be hyper-intense signal, and this one is a stir sequence, and this one is a gadolinium enhanced sequence. When it affects the hip bones or the pelvis, it can look like a diffuse sclerosis. And on MRI, again, you can see the hyper-intense signal. Overall, CRMO, the lesions always appear to be osteolytic and sclerotic, sometimes mixed lesions, and multifocal can be symmetrical. And a lot of the time, long bones are the ones that are affected, specifically at the epiphysis and the metaphysis, and often at the lower limbs. Sometimes the pelvis, vertebral bodies are affected. When it's unifocal, it's often reported in clavicle or mandible. And often we need a comprehensive assessment of all the bones on the body by using whole body MRI, bone scan, or PET-CT. But even if so, our question is always about how to differentiate between this condition with bacterial infection of the bones or tumor. In fact, chronic recurrent multifocal osteomyelitis is diagnosed by exclusion. And often a few other investigations will help us. For example, inflammatory markers. It's usually normal or only mildly elevated. And bone biopsy will be able to tell us if it's infection or if there are malignant cells. And often some bone parameters on blood tests will be helpful. For example, LDH, uric acid, ALP, and calcium phosphate. Bone culture. And MT2 IGRA test looking for TB, and bacterial culture and PCR will be also telltale of any bacterial infection. And our usual blood tests for autoimmune markers, for example, ANA and HLA-B27 will be negative in this condition. Here is a list of differential diagnoses. So infections and malignancies are the big groups, and also rarer, there is the metabolic bone disease, for example, scurvy, where in less developed countries where there is vitamin C deficiency, it can also present something like this. And some people also created criteria trying to avoid invasive investigation, that is bone biopsy, by creating some criteria, trying to avoid bone biopsy in order to diagnose CRMO. So these are the Jensen criteria and Bristol criteria. They are looking at the radiological features and also the symptoms and blood tests to give us more evidence of CRMO without doing a bone biopsy. And on to the treatment of CRMO. The first-line treatment is to suppress inflammation by NSAID, naproxen, for example. If it fails, then we consider corticosteroids or some conventional DMARDs like methotrexate, sulfasalazine. And the next step, if it's refractory, would be biological DMARDs, for example, the tumor necrosis factor inhibitor like adalimumab, etanercept, and infliximab, or the interleukin-1 inhibitor canakinumab. And another identity of drug that can be used is bisphosphonate, for example, permethrinate and zoledronic acid. Bisphosphonate helps this condition by inhibiting bone resorption and also restoring the imbalance between the pro and anti-inflammatory cytokine expression. In our girl, we started her on naproxen 250 milligram 2 times a day. The girl initially had some improvement, but in fact the symptoms were quite persistent and didn't appear to be resolving after some time. So we started her on methotrexate up to 15 milligram weekly, which is a reasonable dose for this body size. Unfortunately, after a few months, the girl still complained of persistent symptoms, and it appeared not helping. And up to a point, the girl had some ADL affected, so the heel pain caused her difficult to walk, and it was so severe that we decided to give her a short course of prednisolone to suppress the inflammation. And the girl had a good response to the steroid, but after some time, the symptoms came back again. So we proceeded to give her permethrinate infusion. It's given as a 3-day course for each cycle by the IV once every 4 months, and she received 3 cycles. Just to introduce some of the common side effects of permethrinate, they include flu-like symptoms or infusion reactions. And after the infusion, we need to monitor some possible side effects, for example, renal dysfunction, electrolyte disturbance, for example, hypo-K, hypocalcemia, hypophosphatemia, hypomagnesium, and we also need to check the blood count for any cytopenia. And also one of the well-known side effects being osteonecrosis of the jaw. So this shows 2 bone scan of this girl pre and post treatment of the permethrinate infusion. So this one is the pre-treatment and this one is the post-treatment bone scan. As you can see, they look pretty similar, but suggest no significant radiological improvement. And in fact, clinically, the girl also didn't have a significant improvement. The asymmetrical increased uptake over the wrist, the right calcaneum is the same. So we needed to step up our treatment. We gave her adalimumab, anti-TNF alpha, by the subcutaneous route, 40 milligram every 2 weeks. And after around a year, we repeated. After half a year, we repeated MRI for this girl. So this one is the pre-adalimumab MRI, which shows the heterogeneous signal over the right calcaneum, and it disappeared on the MRI this time, showing very good improvement. And the previously hyperintense flexor hallucis longus tendon also is less obvious compared to the pre-treatment MRI. And the girl, in fact, had better heel pain and right ankle pain at this time. How about the wrist? So this one is the pre-treatment one. You see the hyperintense signal. This one is a post-treatment, post-adalimumab MRI. Both the wrist bones look pretty similar and symmetrical without any hyperintense signal, which is good. And somehow, after some time, it's interesting that when we repeat the X-ray for this girl of the wrist, this one, the right wrist, was the previously affected wrist, which we diagnosed the chronic recurrent multifocal osteomyelitis, and we see some lines like a zebra. What is it? Yeah, it is a zebra sign, and it describes the dense lines in the metaphysis of the long bones. It is a marker of us giving a child cyclical bisphosphonate therapy in a growing child because there is formation of some cartilages which are denser and less calcified, so they appear to be clear lines. And the number of lines can suggest the number of cycles of treatment received. And interestingly, the spacing between the lines would suggest the amount of bone growth that occurs between the treatment. So, in short, a zebra sign indicates history of receiving bisphosphonate therapy, and is nothing of a worry. So here we can appreciate the overall timeline in terms of the bone scan of this girl. Initially, she had obvious asymmetric uptake of the affected joints, and over time, this one is a post-adalimumab one. The right wrist now looks pretty symmetrical over both sides, and also the left wrist improved, and also the right ankle also now looks less increased signal uptake, and also the previously asymptomatic affected sites, including the humerus and also the right knee, also showed improvement. And in long term, the prognosis of this disease is relapsing and remitting. In the largest cohort so far, with 178 children in France, it's reported that after 4 years, around half of them achieved remission, meaning another half would still have relapsing and remitting course. In another cohort of 80 children in Germany, after 4 years, 2/3 of them achieved clinically inactive disease. And this picture showed us the prognosis and possible complications of this condition, which are leg length discrepancy and also compression fracture over the vertebral bodies when it affects the vertebral bodies. So in summary, today I've introduced a rare condition called chronic recurrent multifocal osteomyelitis. Sorry, it obstructs the names here. And I've introduced the common features, often mimicking other differential diagnoses, for example, osteomyelitis and malignancy, and it has to be diagnosed by exclusion. And treatment is variable and individualized, and the prognosis is often a relapsing remitting cause. And this is a foundation in America where they set up this group and trying to increase the awareness of this rare condition, and hoping that in the future, with more researchers, the overall health and also ADL of these patients can be improved. So this sums up my presentation today, and I'd like to end my presentation with the QR code of MCQ. Okay, so you're welcome to scan this QR code. It will lead you to a question. Sorry, it's a little bit too big. Let me see. Okay. My question is, which of the following is not a treatment option for chronic recurrent multifocal osteomyelitis? Is it antibiotics, biologic, permisionate, and corticosteroids? And congratulations, all of you get the correct answers. Thank you.
So thank you, Dr. Kwong, by presenting this interesting rare case in pediatric rheumatology. So the first section is going to end. So I welcome any questions on the floor or in the Zoom. So I would like to invite Dr. Yang and also Dr. Kwong to the stage first to answer any questions from the audience. So at this moment, I'm waiting for a question from the web or floor. Maybe I'll start the ball rolling first. Maybe to Dr. Yang first. I would like to ask, in approaching the children with some limping gait or joint problem, as you say, we will need to differentiate whether it's infections or inflammation is the most important clue for differential diagnosis. Can I say if a patient turn up to me with some acute problem with just one joint problem, is it more likely to be some infectious cause, or for those with multiple joint symptoms, can it be more likely to be in some inflammatory process?
Thank you, Dr. Lee. So, of course, if a patient presents with multiple joint problem, it's more likely to be inflammatory. Very rarely do infections spread that badly, and the patient still can walk into your clinic. But for monoarthritis or just one single joint involvement, sometimes it's not so easy. So if you see someone who's very septic, of course you have to think about septic arthritis. But of course, like for someone with, let's say, osteomyelitis, usually they're less septic. They might still have fever, and of course, let's say our JIA patient, let's say first presentation, one joint can also have fever. So sometimes it's really not so easy to differentiate. Both can have fever, both have one joint swollen or somewhere close to the joint swollen. Both have elevated inflammatory markers actually. So sometimes the first thing you can do, apart from some blood tests, of course blood culture you should do if there's a fever, because actually 50% of the cases with osteomyelitis, they will have a positive blood culture. And you can go on to some imaging. For example, if you do an ultrasound, like a POCUS ultrasound, a really focused ultrasound, seeing if there is any hip effusions. If there's effusion, obviously it's either septic arthritis or let's say JIA, inflammatory arthritis. If there's no effusion, not so septic, maybe you will look for any osteomyelitis. Yes.
So thank you. So maybe the next question I would like to ask Dr. Kwong. For the case of CRMO, so usually do you notice any complications of these patients when you are treating them? And secondly, when you, as you say, there's no raise in any inflammatory markers for this kind of patient. So when they come to you, what kind of clinical parameter you are going to assess to see whether the disease progress or it has become more control? Last question is, how long will you use the treatment, for example, biologics? Because as from some study for the prognosis, just only 40% of them remit and 40% still need ongoing treatment. So is there a lifetime long biological treatments for this kind of patients?
Thank you, Dr. Lee. So for the first two questions, in fact, the inflammatory markers can be normal or mildly elevated in these patients. And in our patient, we monitor her progress using serial inflammatory markers and also clinical, and followed by the interval radiological scans. And as this condition, CRMO, is very rare in my experience, I haven't seen many cases, and in this specific girl, she seemed to enjoy good recovery, and in fact, right now, she enjoyed asymptomatic or remission clinically, and she had no pain, and we are still putting her on continuation of biological therapy more than 2 years now, and she is still on adalimumab every 2 weeks. And because we know that this condition is often relapsing and remitting, and in rheumatological disorders, we tend to believe that treatment more than 2 years would reduce the risk of relapses. And so I think overall, a prolonged course of therapy is helpful to our patients.
So what kind of radiological investigation that you are going to have follow-up? Like MRI or bone scan, which one is more appropriate, and how frequent you are doing, what interval you are going to do it?
When the patient was still symptomatic back then, we were quite troubled by the persistent disease, and so that's why we ordered both the MRI and also bone scan. But of course, we know that bone scan has the risk of radiation. So in fact, MRI can be better imaging option, and but in the contrary, if the patient complains of new onset of new sites of joint or bone involvement, then I think a bone scan will be helpful because we're looking at new lesions over different sites of the body, whereas we seldom do a whole body MRI in our setting because the radiologist often agrees us to do only localized MRI at specific joints. And right now, as the girl has no more symptoms, in fact, we are not arranging a very black and white regular MRI at this junction, and we tend to monitor the clinical instead.
Thank you. Any further comment from Dr. Young?
Oh, good. I think bone scan, often we want to look at the different sites because you can see the whole body at the same time. Whereas MRI, as Elaine said, probably we're not going to get a whole body MRI. Hopefully we can do that in the future. But as of now, it can focus on the sites that you know that are affected. So you can look for any, look at the inflammation and the structural changes. So I think that's basically what we're doing.
So thank you. If there are any further questions from the floor or any questions from the web? If no, then I'm going to end this section, and thank you Dr. Young and Dr. Kwong for their excellent presentation for this case and also discussion around about the information or any infection caused of a joint problem in children. So we are going to have a 5-minute break, and then we'll come back in the second section. So thanks a lot.